Welcome back. You're watching Daybreak, and I have Dr. Davji Atela here, Secretary General of the KMPDU, and I have Terry Ramadhani from the KEMSA, that is Kenya Medical Supplies Authority. And I want us to begin the conversation on the state of the healthcare by listening to a conversation that the CEO here had with some members of the National Assembly Committee on Health sometime last week. Watch.
Dead stock comes from having an excess of commodities that you don't need. And then they end up, expiring. So that's a challenge we have addressed, and we have cleaned up our pipeline to focus on 100% the critical items that Kenyans need. The reforms continue in full gear. As Honorable Nyikal has indicated, we've had some challenges in terms of execution of those reforms because of the litigation, and we are respectful of the court processes as an institution. We currently have about over 400 people working from the office, so we have good capacity. The people who are working from home are also coming in whenever there is need for people to boost up some operations.
All right, and let's begin there, because I think it was around this time, well, early in November last year, that the board made a decision that they're going to restructure how KEMSA works, and therefore close to half of the staff was supposed to be rendered redundant. That was taken to court and sort of halted. How has it been, and how are you managing your staff at the moment?
Thank you, Sam. The journey has been long, and it's been, with a myriad of challenges, but we're making progress. But, KEMSA's mandate is a very simple affair. I know when you read the act, there's so much, but it breaks down to this. We buy, we store, we distribute medicines and equipment to the farthest corner of this country, because we do last mile delivery. And that is what we are focused on doing. So even with, the different challenges that are there, we can't sort of close the doors and say, okay, KEMSA is closed for repairs, see you in the new year. We have to continue doing what we need to do, until everything else settles down. We still need to get the medicine to Mwananchi. The medicine still needs to go to Mashinani. So yes, it's been a challenge, but a lot of, pressures, but we are focused on continuing to make sure that we are climbing that ladder of getting the medicine to Mashinani.
And how many staff members are still working from home?
As I said on that clip,
you spoke of the ones that come to the office.
Yes, but you may not have captured that bit, but we actually also spoke about the ones who are at home, who are about 300, yeah.
300. So what exactly do they do from home?
They contribute in different ways. Some are collecting debts, helping in those efforts. Others come in when we need them. And then you must remember that we also have quite a number of them who I believe are busy with the litigations against the institution.
So they're not actively working for the organization? How many?
Well, I can't speak for them, but...
No. Okay, because I thought the ones that went to court were about 44, so I'm just...
No, they're over 70.
Over 70. Okay, so maintaining them, because the board had already made a decision that some of this, we don't need them. We're giving you a notice of 1 month. Be working from home, but there's a possibility of being rendered redundant. So is there value for money?
So first, I think there needs to be some facts, setting some facts right. Section 40 of the Employment Act speaks to how it is you deal with a situation of restructuring when a decision is made. That at the very first instance that an institution contemplates that they are going to make some changes that may result to job losses, you must inform the employees. So that notice for redundancy is what was issued. That was not to say that you have 1 month until your jobs are gone. It was to say that now that we need to have this process, we now need to have a conversation about how it's going to go. because that section of the Labour Act is very clear that opens a window of engagement. You start to have conversations of why is it that we need to do things differently. And frankly speaking, I think the case of why things need to be done differently is well made. You know, we all know the challenges that have been in the institution. And once those conversations are had, and then you start to roll out the new jobs. So there was nothing like, you know, a 1-month notice to jobs ending. But now that the courts, you know, made the different rulings, we do have, you know, some kind of that situation that you're describing. Because on one hand, we have the court orders. On the other hand, we have what is best interests for the institution. And remember, you know, having asked staff to work from home was also in preparation for the execution of the new structure, right? KEMSA has or had 920 odd staff. The new structure has 378 jobs. You know, there's a huge disparity. Now, if we were able to have gone through that process by now, we would have settled and moved on. But we are respectful, as we said, of the court process.
That's interesting, but in the end it comes to there are people that are going to lose their jobs based on a structure.
Yeah.
Your chair, Mwadime, said on that day, I think it was 4th November 2021, the release of all staff to work from home is a procedural formality to facilitate the review of the organizational structure and will be undertaken expeditiously to ensure that the staff complement is fit for purpose and within the approved staff establishment levels. And so, I mean, so it adds to what you're saying, that you had an establishment of 922, you needed to have 378, so that's a reduction of 544. So I'm just wondering, even if they're working from home, and yes, there's a court process, how much money are you spending on them? And in the end, is it value for money? What's best to happen in the shortest time possible? Because the word was expeditiously.
What is best to happen, because we are talking about value for money, in my view, is for the institution to have the numbers that are most optimal. Because that 378 was not just a number. You know, it was a process that was interagency, that was geared at best practice. How do you have operational efficiencies? You know, what do they say? That too many cooks spoil the broth, right? So you have 3 people doing the work of 1 person. You're driving operational efficiencies down, as opposed to increasing the efficiencies, you see? So that's the same situation that we are dealing with. With the staff that we have working from the office and bringing in the ones who are from home whenever we need them, we have managed to bring up our order fill rate from 18% to 60%. Our turnaround time from 46 days to 16 days. You know, we have managed to take other really big initiatives like closing all the leased warehouses and saving 200 million. I mean, you have to ask yourself, per year, you have to ask yourself, you know, how are the operations efficiencies working? Is it when you have the bloated staff, where you have now a lot of people who are not engaged on delivery of service, they're engaged in other activities, you know? And we live in this country, Sam. So, you know, when we say in other activities, then we really know that, you know, and in fact, I really appreciated one of the members of the county assembly. They talked to the fact that, you know, internal sabotage is worse than open rebellion, you know? So when you have an institution of 922 people and you only need 378, then a great majority are involved in other things other than working.
That's interesting. I'll get back to that. Daktari, I don't know if you've worked with a public institution, but what would be your experience in the efficiency of KEMSA, and also from what you've heard from your colleagues in terms of supporting patients, because a doctor will prescribe, but they cannot go to buy the medicine for them. How has it been?
I think particularly on KEMSA, I think KEMSA is the backbone of healthcare operations in the country. Because, and particularly for the public healthcare, this is because the regulations makes all the county governments and all the public facilities that they can only procure these drugs from KEMSA. And therefore, one thing that was happening in the previous days is that KEMSA was laden with a lot of cartels and corruption in it, to the point that the drugs in the public sector was getting more expensive than the private sector. And I think there were a lot of, even if you look at the COVID-19 time, we had COVID-19 billionaires. They all emanated from KEMSA. So to a point, in fact, those first went to court when KEMSA was doing restructuring, is KMPDU. And the reason is the way that was undertaken. It's good to do the restructuring because we support the restructuring because we want the medicines to be available everywhere so that the management or the quality of healthcare can actually be received by everybody. But then it should not be done against the human resource guidelines and procedures. I agree with Sister Terry on the approach, but it will be more important to have engaged the staff first before giving the notice for redundancy. You mark them, understand. And it also doesn't make sense to declare redundancy and advertise for the same positions that those particular ones are being declared redundancy qualify for, because that's what was happening. Then I think also some of the aspects of rather restructuring and sending all these numbers home is a way, to some point, just to, it's a way of going for the small fish when you're leaving the big fish, because this thing went into Parliamentary Accounts Committee, and they gave reports on those who are capable to make KEMSA not work. So it means the logic to come for those technical workers to be part of this, when those who are, the reports are there from the EACC, the reports that are there from the PSC are not being done for anything. In fact, they're being rewarded and lauded. So that's why it has received a lot of pushback. Some of those, like the chair of the board at that time was appointed to the Communications Committee, Communication Authority, after the public accounts reports and after investigations. So you see, that makes the worker, the cleaner there, it makes the person who does procurement, all these people feel like, why is the persons that have been found culpable not put responsible, but then the other staff are going home on their behalf? So it's important that everybody, and actually people who are in the administrations, the bigger persons in the organizations, should put accountable for all this. And this is what we always say every day. Right. Sometimes, when an organization like KEMSA doesn't run, it is not the issue of the junior staff. It's always the issue of the big people in the organization, and probably sometimes in cahoot with the Ministry of Health. Okay.
And Terry, I'm just wondering, because you said that, yes, bloated sort of, how do you call them, establishment. Should I actually use that word? Because establishment is what is allowed. But you had more workers than you needed. And you're saying that they were engaged in other activities, but the core mandate of KEMSA. And there had also been what he's referring to, if you remember, the COVID billionaires. So these people that you are asking to go home, that you're planning to render redundant, what ranks were they?
Some, it was a mixture. But if we stick with, with what, for a minute, with what Daktari here is talking about, number one, nobody was earmarked for redundancy. Number two, all the jobs in the new structure are open for everybody, including the ones who are working from home and the ones who are working internally and other Kenyans generally. But why is this process important? It's important because when we walk around, we don't walk with stickers on our heads saying, me, I'm not interested in service delivery, or me, I'm a thief, or me, I'm a what. You have to go through a process that will help you to establish, one, what is the core set of values that this particular person is bringing, because that then informs the orientation. Are they really going to be focused towards service delivery? So this really was a process to help us get the institution, have the best skill sets, the best competencies, the best Kenyans to do the job. Whether it is the current ones, whether it's the ones working from the office or from home or from, or who are not within KEMSA, that we actually get people who are focused on delivering service, So it is not that, there will be punishing of anybody. It's actually not punitive. It is looking to fix what the situation that there is already exists. Because at the end of the day, I keep reminding even our staff, this patient in whichever corner of this country, is not going to wait for us to finish our discussions. They are still waiting for the medicine, you know? And just as the president has been saying, that getting the medicines to where they need to get is a must. It's non-negotiable. And we had committed to deliver that. Now, is there any process of transformation that is not messy? Absolutely not. They are all messy, you know? And as Daktari started off, you know, earlier on was talking about getting things to move. You always have to be disruptive. Yes, transformation is also about disruption. You know, so it is important to bear in mind that this is not a neat situation that you can cut up into small slices and they're all the same cubes and the same whatnot, you know? But he has also made another important point, that for KEMSA to get where it got, even with the crisis that was recent, there were a lot of deliberate choices made by people who are in positions of authority in that institution.
Does the management of KEMSA know who was involved in what?
We don't have any of those reports other than what PAC, you know, gave us, what the Senate gave us, what, you know, all those recommendations. But remember, this matter was already being canvassed by various agencies. The board at the time took the administrative action they did, which was to do indictment on some of the senior members, right? But then that process was also taken up by other institutions that have been running with it. But the truth is, because I think it's important that we get to a point where we tell the truth, part of those very senior people are also, you know, some of them are even at work by court order, that you have been suspended from work because you are going to be investigated. And then you go to court and you get a court order that brings you back to the office, which means there can never be an investigation that is fair because you're sitting in the office, you know? Those are the realities. And when this member of parliament, he talked about internal sabotage, well, it is real. It is very real.
So how do you get out of that?
Well, we have to keep pushing through the reforms. There is no other way. You know, I liked the words, again, that Daktari talked about. They are cartels, they are what? The truth of the matter is, there is nothing illegal that was done about the way the redundancy process was approached. The conversations of reforms actually began even before this announcement of redundancy. Because remember, as soon as the issues around what happened with COVID came on board, the Ministry of Health was very quick to put together the KEMSA Reforms Implementation Committee. The CRIC committee was put together very quickly. And it was made up of some of the staff members in KEMSA to look at what is happening, what is ailing us, how do we fix what is going on. So it is not entirely true that, you know, the first time that all these conversations came to place was at the court order. It may be true, as Daktari says, that the engagement with external stakeholders was beginning to happen at that point. Okay. But we did engage the external stakeholders, and I'm happy to say that though Dr. Bimji and KMPDU were the first to go to court, they were also, I think, the first ones to withdraw their matter after we had engaged quite extensively and understood what direction we were going to.
And so, Daktari, because, I mean, it's sad that that issue of COVID, or the millionaires or billionaires, is still fresh in the minds of Kenyans. There was a directive by then President, I think it was October 2020, that investigations be done and concluded and people held culpable. It's been some 2 long years and we still don't know what happened. But how do stakeholders like yourself help facilitate reforms in such an organization despite all these mixed interests that come?
You know, one thing with the one thing that happens that, and I wanted to say with KEMSA that makes it not really move forward is there's always a procedure and law in all these redundancy thing and even in dismissal, any aspects. But at this point, when you've not engaged the particular staff, you've not make everything be into the procedural within the law. That's why everybody who feel afflicted by the decision made will run to court and stop it. And as we speak, I think more than 9 or so cases are there in courts over the same. But I still say the same thing that I haven't told the board chair, that if the objective of KEMSA is to make sure that there's medicines and drugs to every Kenyan in every facility, public facility. And if this is the objective, that's what the civil societies will want, that's what the unions will want, that's what the workers there will want. And therefore, if these workers then are given the dignity that they deserve to understand and to know that this is your job, at this point is not necessary. We are going to put a structure that will have a particular number of staff that we need. But you see, for example, the pharmacists that were there, they were told that same thing, but the jobs that were advertised were within the scope. So you're told that you have been redundant, but you can apply again. That's what was making these things difficult. But I believe with consultations, with discussions, because these are public institutions, they're not private and they're not, even the private ones, you can't just wake up and say somebody's redundant, because the labor laws are clear on these. So we support the reforms strongly, but we want it to be done such that there's dignity to the workers there, there's dignity to the public, and there's ability for every person in the country to get the drugs
But
timely.
this process is stalled for, it's been a year now.
It has been stalled because of the different court reactions to it. And there's one thing that we keep on saying, and in fact, I was telling the board the same thing. It will continue being stalled until they open up to believe that there's flexibility. You need to have a particular stand that you can never be. There's one time the CS Health, the former CS told me that those who are in KEMSA can never come back again to work in that particular institution. That means you have a fixed mindset that these are the people who were involved in corruption. That again? The former CS, or Kagwe told me that last time, that these are people who are involved in this and they can never come back. They have to go. That was part of early this year. So you see, when that stand exists, then it's very difficult to have a constructive discussion. But if we know that we want to work for the public good, then we must all be flexible to change. We must all have an agreeing point.
Terry, your chair that time said that they were in talks with the National Youth Service to assist in some of the operations. Did that happen? Are they helping now?
No, we did not have the National Youth Service or the KDF as contrary reported. But, you know, because I feel that what Kenyans really want to know is how the medicine will get to mashinani.
Yes.
Not, you know, all these other things that we keep litigating about. But before we even speak to that, let me respond on one item. You know, the matter that we've discussed in terms of the process was prosecuted in court and a judgment was issued. That the process the board used to give the notice on the 1st of November was correct. That people going to court and stopping that process was premature because you want the process to go ahead. Then now you can go and say, we were aggrieved. This didn't happen according to the law. That judgment was issued, you know? So when I say that the process was followed according to the law, it is true. Now, fast forward, I am CEO in May. I have personally engaged every staff member on why we need to do this physically. Went to all our depots, all our warehouses, and spoke to each member of staff. So there is no darkness in how this is happening. Now, as to who gets the jobs, we have said everybody is eligible. But you will have to be suitably qualified, you will have to be well vetted, we will have to see your orientation, because at the end of the day, we have to have a team that is focused on delivering service to Mwananchi. And that is what we need to keep focusing on.
What's stopping you from doing that?
We are delivering service. That's why I told you, order fill rate.
What's stopping you from reorganizing?
Because, again, you know, we haven't finished all the court matters. So that one, the judgment came. And then the same, you know, the same matter was appealed and appealed and appealed, you know. And come on, we live in Kenya. Okay. You know, we know how litigious we have become.
Tell me, how much is your payroll worth?
90 million.
90 million?
Yeah, per month.
And that is for 922?
No, yeah, for 922.
922. So you want it to come down to?
About 60 million, 50 million.
50 to 60 million.
Yes. And why do I say 50 to 60 million? Even though the numbers may be less than half, we want to do just what Dr. Bimji is talking about. I'm in agreement with him. People must be treated with dignity, which is why I've also taken time to engage all our staff. We must have a few human face, even when we are doing very difficult things. But we must also understand that the jobs created, you know, are higher quality with better benefits, you know. So you don't want to say that we are going to make this the cheapest, you know, payroll in terms of payment to your employees. You want to give them good quality jobs, but also pay them competitively.
Right. Okay, and I want us to focus on the doctors themselves, because just last Sunday we listened to the clip that you gave there. And you are threatening that you're going to proceed on strike because there has been challenges in implementing your CBA 2017-2021, and that you have also been ignored. You've not been included by the new government. What exactly is the problem?
Yeah, see, as a KMPDU, we are a members organization. And as one point, we always say that the bottom-up approach to functionality or to leadership is actually in our union. So last weekend, we had what we call a special delegate conference, where you have doctors all over the country. There are about over 500 of them. And we had a discussion and a tally to the CBA 2017-2021. The CBA was painfully gained because it was signed and registered after 100 days strike. That means there's a lot that went into it. Mm-hmm. But I will tell you, Sam, that it's 5 years down the line, but that CBA has not been implemented. We are in the process to start negotiating a new CBA, but when you look at the articles of the CBA 2017-2021, they have not been implemented. The first thing on that is we were to have employment of doctors, 1,200 every year. But we have seen situations whereby 1,200, 1,200 every year, as per the CBA, as per the agreement. But we've seen a situation whereby the doctors who are coming to this conference will strongly elucidate the issues within the counties, whereby you are in the hospital, you are the only doctor in a level 3, or at a level 4, a level 5. For example, take a level 5. In the whole big hospital, there are only 7 doctors. And the same is in almost all level 5s in the country.
Thika, level 5?
Yes, it has medical officers are only 7 who are working in all the departments. And that's the scenario which was...
They are specialists.
The specialists are there, yes. But see, now the specialists work in the different units. But now, for those who do the normal operations of every day, we have like only 7. And this happened, this was the same case we saw in Mama Lucy, where there were only 2 doctors at a particular time of the duty, one in the clinic and one in the theater. And that is a case that cuts across the country, that shortage. Mm-hmm. So you find that those doctors who are working there cannot go on leave, they're overworked, they cannot do anything. Mm-hmm. That's one thing that is there. And then, while this is happening, we have production of about 1,000 doctors every year. So there's highly unemployed staff in the country. So that's the first that we looked at in that particular CBA. The second thing is we looked at the issue of internship. Mm-hmm. We have, for the first time, interns staying out for over 1 year. You graduate, you are supposed to be licensed, to go for internship and then get licensed. You stay at home for a year. Some even for 6 months. So this is currently happening strongly. We have the issue of postgraduate training. We need specialists, and that's why hospitals, like the case of Mr. Travis and the case that happened at Mama Lucy, we need specialists. But because they're not there, all the level 5s in this country will always rush for emergency cases to KNH or KUTRH mm-hmm. or MTRH. And therefore, we say that for us to have a better healthcare, we need to have the specialists. Okay. We need to have them trained.
So for a hospital like KNH, what is the establishment there? How many doctors?
As of now, I think KNH has about 200 doctors.
200?
Yes.
Okay, we'll get back to that. Just hold that thought, because you need to cross over to Kilimani Primary School, where Prime Cabinet Secretary Musalia Mudavadi is there witnessing the start of day 2 of KCPE assessment. And of course, it's at a time that President William Ruto is also at Joseph Kang'ethe Primary School in Kibra, and the Deputy President, that is Rigathi Gachagua, is at Komarok Primary School in Nairobi. And of course, this continues. So that's Musalia Mudavadi, and then that's Rigathi Gachagua's school, or rather the school that he is visiting, Komarok Primary, as the learners begin. That looks like it's an assembly. So we'll be sure to take you back there as soon as possible. Now, back to the conversation here in studio. And you're saying that you have 200 doctors at KNH, you have 7 doctors at Thika Level 5, you have 2 doctors at Mama Lucy Hospital. How many doctors should a Level 5 hospital have, ideally?
Level 5, just in terms of the medical officers, about 70.
70?
Yes. Level 5 need to have about almost 30 consultants. Level 5 need to have a theater. Level 5 need to have intensive care units. Level 5 need to actually be highly operationalized. It must have all the specialists, like 1 neurosurgeon, 1 anesthetologist. But this is not the case in almost.
So when you say 70 and 30,
in terms of, we have the medical officers, we have the pharmacists, and it is those particular, the general practitioners, about 70 of them, within the credited values from the KMPDC. It's supposed to have about 30 specialists, different specialities. Yes.
Okay.
It has to have a particular number, around almost 200 nurses.
According to the standards.
According to the standards.
200 nurses.
Yes.
And for level 6?
For level 6, it's to about now more. It's more of a specialized unit now. It's to about 200 medical officers, about 100 specialists.
So for the level 5 hospitals, would you know any that has met those requirements?
Currently in Kenya, all of them, none of them has met. And that's why we're saying the fact that healthcare is not working in the county is almost deliberate. Yeah. Yes. And it will not work because there's no county that is able to employ currently when they're saying that they have bloated wage bill of over 50% of their income.
And yet, Daktari, some of these hospitals, that's where the doctors, what are they called before they become doctors? The students. Yes. That's where they're supposed to go for training. Yes. Do you think they get exposed to the right training and equipment at different hospitals?
There's a research paper that was done by KEMRI that was released last month that indicates that the internship in the country, because there's a particular number of specialties that need to be there, that about 60% of the internship centers do not meet the requirement because they don't have those particular specialists that are needed in those particular hospitals. And those counties can't employ, and they have not employed. And this is something that is it's a research paper. It's not just something that we say. So that means also the interns that are going to these particular facilities for internship where there are no specialists in the right numbers, that competency and that confidence that they need to gain from the internship actually is not as high. And that's why we are saying that we've seen a lot of lip service. We've seen a lot of political talks about the healthcare. It's a deliberate talk, which is good. But there have been recommendations. There's the Muslim Task Force recommendations in 2012. There have been both Parliament and Senate reports over the year when issues happen. But I can tell you, the issue of Master Travis that happened here and Mama Lucy is what is seen in every county hospitals in the country. At the point that we say that we want an urgent engagement with the government before we give a strike notice, we were actually deliberate and on point to it, and we don't threaten. We actually say that if these things that we're demanding are not implemented as so, then we will have to proceed. And the reason why we're saying that is mostly these doctors that are in the facilities, the first ones to blame have not been employed. And in the case where they have been employed, a few of them, they are not facilitated to offer the services. They actually been facilitated to fail. They've been facilitated to feel frustrated and to be blamed. And that's what we saw even in Mama Lucy.
And so I'm wondering, when you're a medical student, you're going for internship, say you study at Kenyatta University and you're going for your internship at Kiambu Hospital, and you find the establishment there. For instance, if at level 5 there are just 7 doctors, who are you working with exactly? The doctors, the medical officers, or you're supposed to work with the consultants?
You're supposed to work with the consultants, and you're supposed to work also with the medical officers. Okay. And that's one thing that has been indicated, that most of these counties that are there, they end up using the interns as the primary doctors in the facilities because they have not employed. So you see, you are a trainee who should be supervised in your provisions at the counties or at the hospitals, but because those counties have shortages, so you end up working throughout unsupervised. And there's a complaint that has been raised a lot by interns into our committees and even into the KMPDC. And that's why there's actual need to have doctors employed, there's actual need to have the specialists employed because they're there. The country has developed a policy of what you call train and dump. You train like... we have about 9 universities now that are channeling out doctors every year. But you will see from the statistics, even from the one of Council of Governors, that in the last 5 years, they've only employed 10% of those graduates. So it means we have over 5,000 to 6,000 doctors who have graduated and who can actually competently work in these facilities but have been employed. We have also the same interns who have graduated and ready to go into internship but have not been posted. So this is a system that is in existence.
Okay. And Terry, I know you focus on supplying what the hospitals and the governments need, but what needs to happen? Because there are times that people are having a conversation about health. It's 10 years since devolution that people thought that the county governments would actually invest in it and make it better, but it still faces these challenges, whether it's medical supplies, whether it's Oh, sorry, I think we need to listen to the Deputy President from Komarok Primary School speaking to the learners there. Watch.
Very delighted to be in this beautiful school, to come here to give you words of encouragement and to wish you well. First, I want to bring you greetings and message of good wishes from President William Ruto. Mume pokea. The President has told me to say jambo to you, to say he has prayed for you and he wishes you well. We are also here to encourage you and to wish you well and to ask you to be focused. An exam is just an exam. I am sure you are prepared well. The teachers have prepared you well, and you are on your path to destiny. I want to encourage you that what you are going through today is what we went through many years back. I remember in 1977, long before you were born, I also underwent an exam called it was called CPE then, and we were just in an ordinary school. You are even lucky you have shoes and socks, as we were barefooted. We did not even have a meal in the morning, but we were focused, and we made it to high school. Ultimately, we made it to the university, and today we are here serving the people of Kenya. I want to tell you, the sky is the limit. Be focused and concentrate on your education, and one day you'll be men and women of substance. So I want to thank the teachers for preparing you well. I want to thank your parents for taking care of you, making sure that you are well fed, you are well brought up, you have good clothes, and you are in a good position to come to school and learn. I want to thank the teachers who have prepared these learners for the good job that you have done. And I want to say once again that the teaching profession is a calling. Nobody can compensate you adequately for what you do. It's a sacrifice. And that is why we are calling for respect for our teachers, because what they do is a calling. It's such a huge sacrifice. And that is why in our plan in the Kenya Manifesto, we agreed that the process of delocalization should be done away with, so that teachers are able to work anywhere without being coerced to work in certain areas. That is why the President has set up the Working Party on Educational Reforms to look at issues CBC, to look at TVET, to look at university education. And this Friday, we'll be giving the way forward after the President receives an interim report on how we proceed with the CBC and other reforms. So mine is really to wish you well and to encourage you as you go for your exams. Finally, a request has been made about the borehole. That one I'm going to talk to Nairobi Water and Sewerage Company so that by the end of the week it is fixed. I have also been told that you have 27 teachers at a TSC and 5 teachers employed by the Board of Management, which is quite a burden to our parents. And since I've come here, I want to give an undertaking that the 5 teachers that are employed by BOM are going to be employed by TSC in January, when we are employing more than 30,000 teachers. So, munamaliza mtihani siku gani? Kesho. So, alafu muende nyumbani. So, usinipange bash kidogo the following day. Yeah? Hapo iko sawa? So what I'll do, because I've come after you are through with your exams, I'll give the head teacher 300,000 shillings, so that after the exams, you can come and have a bash, muagane kwa heri, sindio? And also we will not leave the teachers behind. I think they have also done a very good job. I will leave 100,000 for the teachers, so that pia hawa washerekee kidogo. Siko namna hiyo. Alafu huyo mjumbe hiyo madarasa mnasema amalize. Wewe Meja Dong ni rafiki yangu, maliza hiyo madarasa ama tukosane. Si mheshimiwa atamaliza. Hiyo ni kazi kidogo, hiyo ni ya mheshimiwa. So we want to say thank you very much and muendelee, and we thank everybody who have prepared these learners, and I'm sure God will give you favor and you'll come out in flying colors so that you go to the high schools of your choice. From there you work hard, you go to university. From there you become somebody and come and serve your parents and serve society and serve the nation. May God bless you and bless you abundantly. Thank you.
All right, Deputy President Rigathi Gachagua wishing the very best to learners of Komarok Primary School as they go to see the examination, which begins in about 50 minutes or so. Now back to the conversation here with Dr. Davji Atela as well as Terry Ramadhani from KEMSA. Dr. Terry is from KMPDU. And you're concluding a conversation on your concerns because the healthcare, the quality of healthcare that you receive it's a collection of many things. It's the facility, it's the stuff you find there, it's the equipment, it's the medical supplies. What do you think we need now to do? Because we've spoken about these problems for so long, but we're still here 10 years later after devolution.
Absolutely, Sam. You're right. I mean, there is space for people to have conversations and discourse and then come up with, you know, it's the whole engagement that Dr. here has been talking about. So I would like to say that, you know, the conversations that have been had since devolution have not been a waste. It has been time for people to process what we now need to do. And I think we're in a good place to really move forward with the actions. Therefore, and you have rightly put it, you know, for us to get an effective healthcare service, we have to have the HRH that, you know, Dr. is talking about, the human resources for health, so the doctors, nurses, and all the other cadres. But we also have to have the medicines and equipment. And then, of course, then the other part is the financing, you know, for healthcare. Those are the three things. But what I can tell you is that no matter how desperate we feel about things not working, I think we have been making progress. It may not be as fast as we want it to happen, but, you know, positive things have happened. And what have we been doing, for example, for us in healthcare, in commodities, in medicines? I spoke about it quite briefly before when I was saying about our order fill rate has improved from 18% to 60%. And I would like Kenyans to understand what order fill rate means, because, you know, sometimes we use all these terminologies and then we forget to break them down. What do they actually mean? Because people are not in that sector. Order fill rate means if you order, ukinunua vitu 100, if we are doing 18%, it means we are only giving you 18 out of 100. So if you have ordered 1,000, I'm giving you 180 only. Now, the counties are right, you know, when they complained, you know, that they are not getting the medicines. Right. So we have moved that from 18 to now 60. So for every 100, you get 60. But that is not good enough yet, because best practice is 95%. And why is this so important? Because, you know, I keep saying, tuna story nyingi, we talk about so many things, but ultimately, the patient anasubiri dawa. That mother who's having a baby is waiting for oxytocin to help her not to bleed to death. You can't tell her, can you plan to have this baby next year when we have finished being disruptive with Davji, and then now you can have the baby. So order fill rate from 16 to 60, and we must get it to 95. That is our target. Turnaround time. Turnaround time means from the time we receive the order at KEMSA to the time it gets to the facility, on average, 46 days is what we were doing last year. Now we are doing an average of 16 days, which is still not good enough. Our target is to make sure that in 7 days, we can take medicine to every primary health center in Kenya. In 5 days, we can take to hospitals. And in 1 day, we can do emergency commodities in 1 day to whichever part of the country. Those are very, very aggressive and ambitious targets. But why are we pushing for them? Because again, the patient, mwananchi ambaye anasubiri hiyo kitu, does not care for our boardrooming, our meeting, our workshopping, our demonstrating, our whatnot. They just want medicines. It's very simple, you know. And why did we close all these warehouses? Because those are the only three things I want, you know, to talk about today. The order fill rate, the turnaround time, and the efficiencies. The other day, Waziri, our CS Health, was talking about operational efficiencies. Operational efficiencies is the top strategic objective that we have in the turnaround strategy for KEMSA. And operational efficiency has a lot of things. And we only have 3 strategic objectives: operational efficiency, customer focus, and repositioning KEMSA. Because surely, if we do not become efficient, we cannot get the medicines to become affordable. We must become efficient. His story that, you know, KEMSA drugs are more expensive than sijui where, needs to become history, you know? And as we get the efficiencies, because of our economies of scale, and other interventions that we are looking to do in KEMSA, including focusing on local manufacturing and getting the products from local manufacturing, then we must get to be the cheapest in every commodity, every medicine.
And tell me here, so that we understand, how do you do your procurement so that you're able to satisfy an order in those 5 days? Do you make strategic procurement, or you procure based on requests from these governments and hospitals?
Our procurement, for best practice, you must procure that is needed. Remember that clip you played, and we were talking with the parliamentarians last week that, you know, one of the biggest things that has been ailing KEMSA is that we have so many of what it is that is not needed. And what is needed, hakuna. Sasa, tunaweza tukajijazia how that has happened, you know. But our focus is now to move completely to focusing on what is needed. We call it 100% VTA. 100% VTA meaning 100% focus on vital commodities, what we call tracer commodities, and Class A for both pharmaceuticals and non-pharms. Why are those important? Vital drugs, that you have an emergency, whatever it is that you really need is available. What are tracer? Tracer is M&E, because what is measured gets done. Tracer items are 67, but that by policy. If you go through the healthcare system, if you find these 67 drugs, it means that the system is working. Class A are the most commonly used drugs. We are focusing 100% on VTA. So operational efficiency must really work. Number 2, customer focus. Tumesahau, KEMSA is for the patient, Sam. KEMSA is not for all these conversations we are having. It's to get medicine mashinani. Ukitoka tu hapa outside your studios, there at the kiosk, you can buy Panadol. But there is somebody, Sam, let me finish, who cannot get paracetamol other than we delivering it. Repositioning is also very important, because we must move away from this story that KEMSA is just about scandals. Hata Rais amesema, the scandals must end. So let's just get that done. Now, you're asking about how we do procurement. The counties themselves, and one of the activities we do is help counties to get the skills to quantify. What is quantify? Say how much. To forecast. What is forecasting? Understanding. Sisi huwa tunatumia paracetamol ngapi? Huwa tunatumia antimalaria ngapi? Huwa tunatumia, and that is based on the number of patients they see and the disease burden of the particular area. So once they do all their needs, they then come to our logistics management information system. They put in an order. Now, based on the history of what counties have been ordering, we order. Because, see, we have that data. We know that County X, huwa tunanunua paracetamol 10,000. Hii nyingine, this. You put it together, unafanya bulk purchasing. Then, we also do procurement for programs. So those ones are GOK, national level programs, ambazo sio za county. So those ones now are for the main strategic focus areas for health, for malaria, for TB, for HIV. So those ones we also procure in bulk. And because we are going to get operational efficiency, we will get the cheapest deals in the market.
I hear you, and I'll get back to that. But Dr. What is the experience of your colleagues? Because sometimes you go to a public hospital, you're asking for some basic drugs, but you're told we don't have them here. Go to another chemist.
Actually, Sam, all the strikes that doctors have gone to, and even we have said we have given the government, both the county, national government, a grace period for engagement before actually proceed to have even the strikes is because of what happens in the counties and what happens in the hospitals. As he says, the essential drugs and all that, when you go down into the service provisions, doctors feel that they're being facilitated to fail. And the reason why they feel this is because you are in the hospital, you have a patient who actually need an emergency drugs, like the mother that is bleeding. You realize that the hospital does not have that particular drug, like oxytocin. You realize that the drugs, the hospital doesn't have even any of those, they call emergency tray. They don't have all the components. You go to the theaters, there is no intensive care. So you're actually not able to operate, not able to work. So you are actually facilitated by the system to fail. So this time, when we are having these discussions of the CBA 2017-2021, it is not for money. There's no salary agreement that we're demanding. We are demanding that these issues of accusations about the negligence of healthcare that actually has been neglected by the government and by those investments that are needed is the issue we want to be sorted. The issue of cases that we saw in Kiambu and in Mama Lucy, there is a replication of the same. Like the month ending November, we have 6 maternal deaths in Kakamega County. These were preventable if the system was working. We've had a mother who dies on her way from Central in a matatu looking for ICU in Kenyatta Hospital. We have a case whereby a mother is being transferred from KUTRH because he can't pay the money to come back to KNH. These are frustrations that doctors are feeling downstairs in the facilities. But how can these things be prevented? Is it just by the lip service talk or by implementations of those contents? As much as the Senate, the Parliament, and all these people are looking for documents, these issues were discussed. There are a way to stop them. And this requires, number one, you must have money in healthcare so that you can have health for money. Right. And for that to happen, we must increase our allocations to the counties. That's the first thing we're talking about. But since that can't happen, we need to have a centralized approach to management of human resource for health. Because for sure, there's no counties that's going to employ healthcare workers if they've not done so in the last 5 years. We are seeing the first time interns graduating and staying over years. So if we have a centralized approach to management of healthcare, then the 60% budgets in the counties that are currently said to be going for wages and benefits for healthcare workers will then now be coming from central government. And therefore counties will be relieved. They'll be able to fund the operations, to buy the drugs, to pay the pending bills in KEMSA and all that, while then the human resource aspect will be looked into deeply. And that's at one point in our presentation at the Senate, we say we need a task force that will then give recommendations that can be implemented.
You know, I'm just wondering because, I mean, these things are known.
Yes.
Speaking to the governors, do you have a forum?
I'm telling you that, and this thing we're telling governors, these new governors must be alive and be objective, and they must see that they can't manage the healthcare, and they can't manage the aspect of the human resource, because none of these governors actually are able to employ. But then you can't employ, and that hospital doesn't have doctors. You realize that the waiting time in the hospitals is over 24 hours now. You will go there and you'll be told to wait because there's probably one doctor in that particular facility. And this doctor probably can't even be in the outpatient setup. He has to be in the clinics and in the wards and the theaters. So you will not see. So seeing a doctor is becoming very difficult. So even when you come out blaming that they're not doctors, they're not there because they've not been employed. Then again, you realize that there are those particular people in the country, the patients, who are being you need to have a procedure. The disease is progressing, but you've been scheduled for next year or for the year after. So at the end of the day, the people who are suffering are the Kenyans. So when we are calling and demanding for these changes, it's not for doctors, it's for the public so that they can get the health care. And this strike that we may call in the coming days, it shouldn't be strike for doctors, it should be strike for the Kenyans so that they can get the health care that they need. They must have the right to access to health care in any part of the country, regardless of your economic status.
Dr. on average, what is the cost of maintaining a doctor in a hospital?
So you see, in the public sector, I don't think there's much. Averagely, we look at the salaries, which are just the normal salaries of about, say, 100 to 200,000 for the doctors in the country. And you see, in terms of employment, we have not seen them employed. So that budgeting aspect, what affects the counties is that the counties have the 15% of the budget for counties is the same one that they use for wage bill and the same one they use for operation. That's what is making it difficult. And at what point you are telling even the NHIF that in their rebut to the public hospitals that are currently doing, as much as it is uniform with the private sector, there's no user fee, there's no cost of the doctor's procedures and operations. That need to be there. As much as the doctors are not going to be paid that money, the money will be injected in that hospitals to increase operations. Because the money that they have, what they have considered in the current regulation is only covering the consumables in the facility. And in that case, the people who would make losses are the public hospitals. So that's why we are saying it's important that we look into that so that we can put more money into healthcare. We look at the budget declaration that has been stated all over the place, that in Africa, only 14% of the countries have looked into it. In developing countries, I think more than 60% of them. And that makes healthcare to be seen. But you see here, we're talking about the universal healthcare when the ability to see a doctor in the hospital is less than 20%. And it's less than 20% because they're not being employed there. The ability to get the services, to get the drugs, and to come out of a public hospital satisfied is less than 15%.
The reason I'm asking that question is because, I mean, you will hire a doctor, yes, you give them a salary, but you'll also have to facilitate them to work in whatever manner that may be. So I'm asking of what would that mean to the counties in terms of their budgeting? Like how will their expenditure shift in a year?
You know, in terms of the salary for doctors or for the healthcare workers, it's a fixed budget. It's something that was from the exchequer. So the counties, the salaries that was being paid for the doctors all before is what shifted to the counties. And therefore, that's why we were saying, and we keep on saying that part of salaries that was to be there should have not been part of the 15% of the budgeting in the counties. Because once you remove that, if we put that salary to be part of the 15%, then all the counties become overburdened, and therefore they can't employ. Yes.
Well, yet reports from the control of budget, I think, consistently say that 40% of the money sent to counties goes to healthcare. So then, the other factor that we need to also talk about, Terry, is because now we're moving to that phase of fixing all these challenges. Do you think, I mean, the competition, because the cost of healthcare has also gone high, you look at the private hospitals, there's the question of insurance and medical covers, and then also there's the aspect of NHIF, usually would be very good for civil servants in public hospitals. The experience for people in the private sector going to a private hospital is totally different. How do we rationalize that so that at the end of the day, we don't have a lot of expenditure in healthcare, yet this money is more or less going to private hospitals and not even boosting how public hospitals can manage with their costing of operations?
I think that the various initiatives that are taking place, for example, yesterday I was in a Kenya Health Financing Forum, and the big push that is being done there is that we must move away from conversations of pooling resources to conversations of the fact that the resources are there, you know, because we must move away from the same conversation and get to a place of action, as you're asking. And so when the financing is working right, when the human resources issues are working right, as Dr. Ari has been talking about, when the medicines are there, you have UHC. You know, those three things have to come together. But they have to be pushed together at the same time. And what I see is a beautiful opportunity where that is actually happening. Because, you know, Dr. Ari is my good friend, and even though, you know, his job is to be disruptive, these conversations he's having here is actually the push for the human component to work as it should. That's why he's talking about the Health Service Commission and all that. So these all three things are coming together. You know, I think we must not lose sight of the big picture, you know, because these are steps and milestones. And in the journey of development, you will go forward, you come back 3 steps. You go another 5, you come back 2, you know. So yes, it can be a little bit frustrating, but these things are coming together. I look at, for example, the kind of actions that are happening in terms of the NHIF reforms. I'm looking at the reforms we are pushing at KEMSA, and I'm looking at what the ministry is doing and the county government's efforts to see how they can streamline the human resources aspect. There is one thing I strongly also agree with Daktari, that, you know, even for us at KEMSA, we have noticed, and there is a lot of data that shows, the hospitals, the level 6s and 5s, actually the level 5s and 4s in the counties, that have been able or have been allowed to keep their fees, you know, the facility improvement fees. And now Daktari is also talking about components of more money for the procedures that can also be left there for, you know, instead of the physicians, that the physicians will not get paid. There is a remarkable difference. Those hospitals actually run a better service, not just for medicines, but even for the human resource component and even for quality of facilities. So I would also urge, you know, that our county governors move with earnest, you know, move quite quickly to give a lot of those level 4 and 5s the ability to keep the facilities improvement fund, because that money allows them to then come directly to us and order their medicines. And the hospitals that we do that with, you can see that they do not experience the kind of stockouts that the other facilities that don't have that access have. What that will also do, it means that it reduces the time from ordering to bringing from the level 2 facility to bringing the order to KEMSA to a shorter period. Because we have done some research, and one of the study parameters that have been established by one of our partners is that from a level 2 to when the order comes to KEMSA, it can take up to 90 days. Now, forget about our internal processes in KEMSA, but even before it comes. Yeah. But if there is a facility that is a level 5 in a particular county, and this facility is able to actually come directly and order, then there's the next step that the counties can have a conversation of how does this hospital become a hub for several level 2s, for several level 3s, you know, so that we are bringing the medicines faster. So there are a lot of opportunities. You know, I don't like, you know, believing that there are no opportunities. In every crisis, there is an opportunity. So let's find them and see how to expedite, you know.
And Dr. the reason I'm asking that question is because I don't know where you go to hospital when you don't feel very well. Okay. I don't know whether you go to a public hospital, but the difference is clear. But also the difference in cost is also clear, that the private hospital, you have to pay for it. Either you through medical insurance, or if you're cash paying, then it's substantive difference between that and the public hospitals. How does the costing of services affect the quality by and large, despite the fact that the public focus is access to health for all in an affordable manner?
And when you look, first of all, in the, let's say that this part of the insurance in general, the current rebates that have been negotiated and agreed by the NHIF, we looked at it that it doesn't have the component of the user fee, where it has taken into considerations only the consumables for the particular procedure or for the hospital. And this is why it's only in the public sector that have accepted it. The privates have not accepted it yet. And therefore, there's need, or what you're proposing, there's need to have this user fee, the doctor's fee, or the part component to be part of it so that it can be invested in the public hospitals and also to allow access also in the private hospital. Having said that, I think private insurance companies are, rather, would I say, scandalous or the den of corruption for healthcare in the country, because they have come up with mechanisms that are bring about inaccessibility of healthcare. Why am I saying this? They've brought what we call empanelment. You have particular situations and you choose particular doctors who can actually offer the services. So they will go to Nairobi Hospital or to any hospital. But when that doctor is not there, then you can't access services. And when, for example, even Britam or Jubilee or any of these insurances, for example, the one in taken by Machakos County or Kitui County, is it? There's the Britam aspect. You must actually have a particular doctor who has been paneled for you to see the services. So this empanelment reduces access because they don't have ability to accredit who should practice. This is the job of the Kenya Medical Practitioner Dentist Council. So every doctor who is accredited should be empaneled in any of these private insurances. But they are reducing accessibility because they are choosing particular numbers too. And when you have that numbers, you can control how the service is accessed. So that is reducing accessibility. That's part of corruption and scandal that we see with insurance companies, which is not with NHIF. Because NHIF has accredited all the practitioners that are accredited by the council. And that's what should happen there. That's one thing that we say about that reduces care. Because then somebody, when they're denied the service provision because a particular doctor is not there, then they have to dip into the pocket, they have to do the harambes, they have to look for other mechanisms to get those services. And as union, and I think even associations and all the societies, we're looking into an approach whereby the private insurance companies can actually align to be more, service-oriented than profit-oriented. Yes.
Wow, interesting. And there's still so much to talk about in as far as the sector of healthcare is concerned. We cannot finish the conversation in one show, but we will continue to have these conversations. Thank you so much, Terry Ramadhani, as well as from KEMSA, that is, and Dr. Davji from KMPDU. Thank you for making time for us to have this conversation.
Thank you for having us.
Great, and it continues. This morning, different leaders of the government are at different locations witnessing the start of Kenya's Certificate of Primary Education and KPSEA Day 2. We understand that President William Ruto is somewhere at Joseph Kang'ethe Primary School. You see also there the Interior Cabinet Secretary, Professor Kithure Kindiki, who is accompanying the president. And of course, earlier on, we saw Deputy President Rigathi Gachagua at Komarok Primary School and Prime Cabinet Secretary Musalia Mudavadi at Kilimani Primary School. The next assessment begins at 8:30 in the next 25 minutes or so in those respective schools. And wish all the very best to all the candidates. I'm told that one of the leaders is presenting examination papers to the learners. What an honor. My name is Sam Gituku. See you some other time. Bye for now.